Hi, everybody. We are going to give everyone just a couple of minutes to get logged on, and then we will get started. Awesome. All right. So it is the top of the hour. So just to kick things off with a couple of housekeeping things, and then I will hand over the floor to Eleanor. My name is Brooke McGivern. I am a speech pathologist and the director of marketing and communication here at Tim's Medical. Housekeeping items, if you are wanting ASHA CEUs for this course, it is registered for intermediate ASHA CEUs. And to obtain CEUs through ASHA, you'll just need to complete the survey at the end of this course. I will put the survey link in the chat. And then if you're signed up for emails via Zoom, it'll be sent out again from Zoom, along with some other helpful resources, including the link to the replay, as well as Eleanor's email address. So be on the lookout for that. It'll come out about an hour to a couple of hours after this presentation has concluded. And if you have questions during the presentation, feel free to pop them in the Q&A or in the chat. And then we'll go back over this information at the end of the presentation. And last but not least, if you are interested in obtaining a customized certificate of completion, maybe you need it for state or national licensure, just send us an email at tims-univ@tims.com, and I will put all of that in the chat as well. And with that, I'll go ahead and hand over the floor to Eleanor.
Hi. All right, I'm going to start by sharing my screen and getting my slides going. Give me just a second. Okay, can you guys see my screen okay?
Yes.
Okay, cool. All right. So I'm your speaker tonight, and the course is ABCs for SLPs. So it's airway, breathing, circulation, and the role of medical stability in dysphagia management. So a little bit about me first. Like I said, my name is Eleanor Smyser. I started as an SLP in 2016, and then I became, on top of being an SLP, an EMT in 2020, and then an advanced EMT in 2023. And so I do both. I do SLP and EMT. SLP is what I get paid for, and then EMT is what I do for fun. I started running volunteer on an ambulance for 911 in 2020, and then I had a baby, and now I do medical reserve corps because it's a little bit slower for me right now. And medical reserve corps is mostly like EMS tents and then like large scale disaster emergency. So I love being a speech therapist and I love being an SLP. And a lot of this course is really inspired by my background in EMS and just the things that I loved to learn during my EMT training. All right, these are my financial disclosures. I work at St. Luke's in Pennsylvania and then also Grandview Hospital, and I'm getting an honorarium from TIMS. So the objectives tonight are to identify 2 vital signs associated with an increased risk for aspiration, to summarize 3 indicators of impaired respiratory status, and discuss 1 way that health status may impact dysphagia management. So this is kind of a general overview for tonight. So we're going to talk about the impact of medical stability on dysphagia management. We're going to talk about how the respiratory system and swallowing are coordinated. We're going to talk about the coordination between the cardiopulmonary system. We're going to talk about kinds of cardiovascular insult. We're going to talk about respiratory failure, signs of failure versus distress, and then real-time indicators of health status and how that might impact aspiration risk. Then we'll talk about some cardiovascular factors in the SLP, and then finally we'll maybe hopefully talk about existing measures, existing formal measures of health status. If I happen to run out of time and don't get to existing formal measures of health status, I did make sure to include all the information I would have talked about on the screen. So if you want the slides, please just send me an email and I'm happy to send them, but hopefully we'll get to it. Okay, so tonight I want to kind of go from looking at dysphagia under a microscope or as like a specialist to looking more through a telescope. So looking a little bit more big picture at the patient and their health status and how that impacts medical stability and how it's impacted by medical stability. So the reason that I chose to talk about ABCs in relation to dysphagia management, which did I say? So it stands for airway, breathing, and circulation. The reason that I chose that to talk about in relation to medical stability is because a lot of times in healthcare and other disciplines, when they're teaching how to do patient assessments, they start with the ABCs, because those are really going to be like your life threats, the things that you need to identify first and be aware of. And I found that thinking about the cardiopulmonary system gives you a really good foundation in where to start with looking at medical stability and looking kind of at the patient as a bigger picture. So starting super generally, why do SLPs care about medical stability? I think most everybody could tell me, yes, of course we care about medical stability, but why do we care about medical stability? The three pillars of aspiration pneumonia are the three things that must happen in conjunction for a patient to be considered at high risk of developing aspiration pneumonia. And those three pillars are serious illness or frailty, the presence of aspiration, and then poor oral health. And if you don't have one of those pillars, the risk for aspiration is going to be super low, or at least significantly lower. So I would say that knowing the presence of aspiration is as important as knowing kind of where your patient falls with medical stability, and what their risk might be for developing pneumonia. So if I had to summarize this presentation in one sentence, it would probably be this. Air goes in and out, blood goes round and round, and any disruption of that process is a problem. I included this because this is something they say in EMS like all the time. I probably heard this like 1,000 times during my EMT training. They start super, super broad with talking about the body systems super simply and get like a little bit more in depth. And that's really where they start. Air's going in and out, blood's going round and round, and any disruption of that you want to try to fix. As an SLP, I would say air goes in and out, blood goes round and round, and any disruption of that process has the ability to impact speech, swallowing, or communication. And what I'm really talking about when I'm talking about how well does the air go in and out and the blood goes round and round is how well is the patient perfusing? So are they adequately perfusing? So that's the process of blood or fluid flowing through the body's circulatory or lymphatic system to deliver oxygen and nutrients to the organs and tissues. So every time that I'm talking about like circulation or oxygen getting where it needs to in the body during this lecture, I'm really talking about how well is your patient perfusing. So I really don't think that I need to go over the respiratory system for SLPs. I feel like we're kind of subject matter experts in that. But very basically, the respiratory system's main function is to facilitate gas exchange, bringing oxygen into the body and removing carbon dioxide. And then, of course, I have some of the pieces of the respiratory system here that I think everyone is probably super familiar with. So I think it's pretty well known that the respiratory system and swallowing are a really tightly knitted relationship. So coordination between breathing and swallowing is a precise sequence. There's a brief period of carefully coordinated apnea during the act of swallowing. The swallowing-related respiratory pause is elicited during the oral phase just before the pharyngeal phase as the mechanisms that trigger a laryngeal exclusion reflex. Oh, that was a tongue twister. But in a normal, healthy adult swallow, that's generally where that apnea is going to be first elicited at. Okay, so we're going to go a little bit back and forth between respiratory and cardiac, but I don't want you to think of it as, okay, we're talking about respiratory now we're talking about cardiac, now we're going back and forth. I want you to think more of it as a system that's working together. So very brief, quick and dirty overview of the heart. The atrium is the upper chambers of the heart that receive the incoming blood. The ventricles are the lower chambers that pump out the blood. And then the aorta is the main artery of the body that receives blood from the left ventricle and carries it to the rest of the body. So how this is really kind of married in with the respiratory system. I'm going to start over here by the lungs on the left side. So in the lungs, blood absorbs oxygen in exchange for carbon dioxide. Then that oxygen-rich blood travels back to the heart and is pumped out the rest of the body via the left ventricles to the arteries. Then the red blood cells deliver oxygen to the cells and remove carbon dioxide. That oxygen-depleted blood is then returned back to the heart via the veins, and then the right side of the heart pumps that oxygen-depleted blood back to the lungs via the pulmonary artery. So really here, all I want you to remember is that the right side of the heart is pumping to the lungs, and then the left side is pumping to the body. So they're working together really closely, and any disruption with one of those things can affect the other. So, for example, with left versus right-sided heart failure, I feel like talking about left versus right heart failure really helps me to understand the cardiopulmonary system a little bit better. So with left-sided heart failure, so the left side's pumping out to the body, right? So the left ventricle of the heart does not pump enough blood to the body. This causes a blood buildup in the vessels that carry blood away from the lungs. So this can result in a fluid buildup around the lungs and shortness of breath, trouble breathing, coughing. And then right-sided heart failure, the right ventricle of the heart is not strong enough to pump enough blood to the lungs, and this results in blood buildup in the veins that carry blood back to the heart. So this increased pressure in the veins can cause fluid buildup. It can cause extremity edema. It can cause fluid in the abdomen. And I don't know about you guys, but I noticed that I feel like I get a good amount of consults for the left-sided heart failure. Not one is because it is affecting the respiratory system. So if they are having difficulty respiratory wise, of course, they're going to have a little bit more difficulty coordinating swallowing. But also just because a lot of times they have that really wet, like coffee pot brewing cough, and they're coughing all the time. So then they're coughing during their meals too, and people are seeing that, and then I'm getting consulted. So I feel like I see a decent amount of patients with that left-sided heart failure. Okay, kind of finally talking about this brief overview of the cardiopulmonary system. I think it really helps to think of that system in terms of blood pressure too, just because that's a number that we're super used to seeing and see all the time. So blood pressure is the pressure of the circulating blood against the walls of the vessels. And your systolic pressure is that max pressure during one heartbeat, and the diastolic is that minimum pressure during 2 heartbeats. So that systolic's that max, and then the diastolic is that minimum, that refill phase. And I know we're kind of, I feel like getting out into space a little bit, talking about cardiac. I'm getting out into space a little bit, but I promise I am going to loop all this back in with SLP. Okay, so keep going out into space with me for a second. Causes of poor perfusion. So causes, reasons that blood might not be circulating efficiently. The 3 causes of poor perfusion with your patient fall into these categories: pump failure, pipe failure, or plasma problems. They call it the 3 Ps of poor perfusion. So pretty much any perfusion issue falls into one of those 3 categories. So your patient can have pump failure. So something with the heart is going wrong. So cardiogenic shock would be the heart itself is not pumping efficiently. Obstructive shock would be something's not allowing the heart to pump efficiently. So like a cardiac tamponade where that blood builds up around the heart, so the heart can't get that efficient pump, or like a pneumothorax where the lungs are pressing, so it can't get that good efficient pump. You can have a pipe problem. So this would be a poor vessel issue. And a lot of times this looks like distributive shock. So the vessels vasodilate, so they dilate, and suddenly there's just too much space for the blood to go, where you're no longer getting that good blood pressure. And this can be caused by septic shock, neurogenic shock, anaphylaxis, psychogenic shock can cause that vasodilation and that blood to just kind of go out into the vessels, and then no longer getting that good pressure for your organs. And then the third kind of failure you can have, they call it a plasma plasma problem, I think just because they're trying to stick with the 3 Ps, but really it's a blood or fluid problem. So not having enough blood or fluid. So this would be hypovolemic shock. You could have hemorrhaging that causes this, or like being dehydrated, not having enough fluid, or an overuse of like diuretics causing there not to just be enough fluid in the body. So as we're talking about vital signs and patient presentation, I just want you to keep these kind of 3 possible causes of poor perfusion in the back of your mind and how these might affect vital signs. Okay, so we talked about causes of cardiovascular failure. Let's talk about causes of respiratory failure. So depending on the source that you use, respiratory failure can be categorized several different ways. This is my favorite way that I've seen it categorized, is either by an inhale problem or an exhale problem. I think that's a super easy, simple way to look at it. And when I say an inhale problem, I don't mean that they're physically, something is wrong with the inhale, but rather the oxygen is not getting where it needs to go. So, or the oxygen is not getting in. And then by exhale problem, what I really mean is that the respiratory system is not removing that carbon dioxide. So you're having a buildup of carbon dioxide in the body. And you'll notice on both of these, there's a lot of overlap for causes of these 2 kinds of respiratory failure. And really that's because generally a problem with one is gonna end up causing the other. So you get enough of that carbon dioxide buildup, that O2 saturation is gonna drop, and vice versa. So there's a couple things that patients can do to compensate for respiratory distress. I like to think of this as swimming. You can either increase the volume or increase the rate. So if you think about swimming, you can either move more, you can displace more water, you can increase that volume, or you can move faster, or you can do both. And there's only going to be so long that you can keep increasing that exertion level until you start to reach that failure stage. So when talking about respiratory distress to respiratory failure, this is kind of a general guideline from categorizing a patient as in distress to entering into more of a failure stage. And usually that early distress stage is going to look like tachypnea. So they're going to be breathing really quickly. And then once you're moving out of that kind of compensatory stage into the exhaustion is when you're going to be really at risk for failure into arrest. And they call these 3 things right here, like the spiral into arrest. So signs you may be entering from exhaustion, failure to arrest would be CO2 narcosis. So that confusion with that increased carbon dioxide buildup and not having enough oxygen, hypoventilation, so their breathing is slowing, and hypercapnia, which is that increased carbon dioxide level. So they're not breathing it off. And kind of very similarly with the cardiovascular system, you can have that compensated stage into decompensation. So that distress into failure. And usually your signs of compensating are going to be tachycardia, tachypnea, and narrowing pulse pressure. So that systolic blood pressure and that diastolic pressure, the numbers are going to be getting closer and closer together because the heart is giving it its all. Signs of decompensation might be hypotension, labored breathing, dilated pupils, poor urinary output. So these are just things to keep in the back of your mind when you have a patient right in front of you. Maybe when I think of this topic, I always first think of, okay, you're in the ICU, your patient's very unstable. But, I think any healthcare setting, you're gonna see a patient that's medically unstable at some point. So these are good things to be aware of. And I even feel like settings where your patients are supposed to be more stable and maybe have less monitoring, it's even more important to be aware of how they're presenting in front of you and what might be changing. Just because they are getting a little bit less monitoring, maybe you're seeing the patient a whole lot more than some of the other staff. So why do we care about if the patient's in a little bit of distress or in a lot of distress? Ideally, for eating, we want the parasympathetic nervous system activated because it's that rest and digest stage. So when the parasympathetic nervous system is activated, the patient's conserving energy, the heart rate is slower, it relaxes the sphincter muscles in the GI tract, and it controls homeostasis. And then when that sympathetic nervous system is activated, so the patient's in distress or they're in that fight or flight, their heart rate is going to increase, the airway is going to open a little bit, digestion is going to slow, and it's going to activate their adrenal system. So I'm not saying that if the patient's in a little bit of distress, they can't eat, don't feed them, but I'll say this a couple times during this talk. It's just another piece of the puzzle to be aware of when you're trying to get that whole picture view of your patient. It's just maybe a little flag while you're looking at your patient. Okay, this is my little caveat here before we jump into health status and the ABCs. The best way to determine medical stability is through discussion with the medical team, awareness of health status indicators, and a thorough chart review. However, given the rapidly changing nature of healthcare, it's important to be able to form general real-time impressions of status when you're with your patient too. I say this only because we are going to talk a lot about indicators of health status, but I'm not suggesting necessarily that you go into your patient's room and say, okay, I've assessed you and you are totally medically stable, or it's going in and saying you are totally medically unstable, but rather just remembering that medicine is a team sport. So maybe you see these indicators and you go talk with the medical team and y'all all kind of form an opinion together rather than just using these tools on your own and maybe scaring someone. Okay, so airway, breathing, circulation, what we came here for, and real-time indicators of health status. And we are going to get back into a little bit more SLP in a minute, I promise. Okay, so like I said, I don't feel like we're going to talk about vital signs, and I don't feel like any one of these things are like a hard stop for eating or swallowing, but I do think some of them are red flags or pieces of the puzzle. The only thing I can think of, well, maybe I shouldn't say this, but as far as vital signs that would be like a really hard stop, like absolutely your patient's not eating, is if like their respiratory rate is 0 and their heart rate is 0. I mean, other than that, you really kind of have to take like a big clinical picture. All right, so indicators of airway and breathing. You'll see I kept the indicators of airway super short. I think SLPs are really good at this. We know what it looks like in there. We know what a good open airway looks like. We know what a kind of less than ideal airway looks like. And we're really good at listening to our patients, how they're sounding with talking, how they're sounding with breathing, and knowing, gosh, that sounds like a good open airway, or it sounds like something is not right in there. So I really just included this one super general sentence about airway. For responsive patients, talking or crying indicates an open airway. Hopefully you're not seeing an unresponsive patient, but with an unresponsive patient, the concern is airway obstruction from the tongue. So the tongue is tonically active to maintain tongue position during inspiration and counteracts that intraluminal negative pressure. So signs of obstruction would be like snoring, stridor, absent breathing, of course. And then signs of adequate breathing, which we're going to dive a little bit more into, would be respiratory rate, the rhythm of their breathing, the quality of their breathing. So is it super labored? And the depth of their breathing. Is it deep? Is it shallow? So signs of inadequate breathing, which this is something that I definitely look really closely at when doing dysphagia management, just because breathing and swallowing are so closely related. And at the end of the day, if your patient's body has to choose between breathing and swallowing, it's probably going to choose breathing. So signs of inadequate respiratory status may be shallow respirations, labored breathing, those use of accessory muscles, retractions, which are depressions above the clavicle and between the ribs, 2 to 3 word dyspnea, so only being able to get out 2 to 3 words at a time before having to get another breath. Nasal flaring can be a sign of inadequate breathing. And then over here, I included some terminology for inadequate breathing. I feel like when I started in healthcare, if I noticed that my patient's breathing was not very good or something didn't seem right about it, I would use language like I just did. I would use very general language. I'd say something seems a little off, like, nurse, do you mind checking them? Something seems a little weird. I just don't feel like they're breathing quite right. But I found that using this like really universally used terminology, more specific language definitely buys me a whole lot more ground. So saying, okay, I noticed that their breathing is agonal. I noticed that they're having Kussmaul respirations. Maybe they're tripoding, so they're leaning forward over their arms and knees. That definitely buys me a lot more ground when describing patients. Another important piece in the respiratory puzzle, as far as real-time indicators of health status, are how the lungs sound. So I won't teach lung sounds tonight because I don't think we want to be here all night long. And if you're not comfortable listening to the lungs, looking at the respiratory therapist note, I have found has been like a really good resource too. But I just included this in here so you have this, and just being aware that the lung sounds definitely play a role in that respiratory status. And I feel like it's most helpful or most important to be aware of when there's been a change. So maybe lung sounds have been great and clear every day, and then suddenly they're wet, suddenly they're wheezing, suddenly they're stridor. That's just going to be another flag or a piece of the puzzle to be aware of. All right, we're going to talk about vital signs now. This is, I think, probably like some of my favorite stuff to talk about. So as it relates to real-time indicators of respiratory status, we're going to talk about pulse oximetry and capnography. So everyone's probably pretty familiar with pulse ox. You've got this little picture down here of a pulse ox on somebody's finger. So it measures oxygen saturation of hemoglobin in the capillary beds. Normally, it's between 95 to 99%, but it can be impacted by a lot of environmental factors. So it can be impacted by temperature, nail polish, carbon monoxide poisoning, COPD. It can be impacted by your patient's circulation. And it's also delayed. So generally, pulse ox shows you about a 60-second delay from what's actually happening in front of you. And it can be even more of a delay if your patient is not perfusing very well. So maybe that blood is circulating a little bit more slowly. Now, capnography, I love capnography. It's not used super often, I feel like, in hospital, but I definitely see patients sometimes in the ICU on capnography, and especially in the ED on capnography. And I think it's because EMS loves capnography and tends to leave it on the patient in the ED. Capnography is the carbon dioxide level in exhaled air. So it's not only measuring like, okay, how much O2 is there, like pulse ox, but it's measuring how well is that cellular metabolism happening. And generally that number would be between 35 and 45. And we're going to talk a little bit more about this too. So back to pulse ox for a second. I don't know if this has ever happened to y'all, but especially when I was kind of newer, sometimes I would go to see a patient who was on telemetry. So you have like the number in the corner of the room, you have their vital signs, and suddenly their O2 sat would drop a little bit. And I'd be like, oh my gosh, like, is this okay? And then it would go back up and I'd be like, whew, okay, we like avoided that one. And I would tell the nurse like, oh, it dropped for a second. And they would say, yeah, but it was all motion artifact. It was fine. Like the waveform was not good. And I had no idea what that meant. But really what that means is ideally you want to see a waveform like in the middle here. So you want to see that good kind of double peak up and down. That shows that it's getting a really good read. If it's kind of crazy, like all at the top, that could be from movement. That could just be artifact. That tells me that maybe it's not the most accurate read. And then this bottom one is low perfusion. Maybe it's not getting a good read. Maybe they're super cold. Maybe something's going on with that circulatory system like that. It's just not getting a good read at the finger. Okay, capnography waveforms. I couldn't help but include this because I really do love capnography. Um, while pulse ox is like about a 60-second delay, capnography is really immediate breath by breath. And it has this nice waveform that's easier to read. It's much more of a pattern to it. It's less affected by like motion artifact. And what you see with this is you see a rise on exhalation, and then you see that plateau, that lowering on inhalation. And the waveform on this can tell you a few things. So it can tell you if they're breathing slowly, if they're hypoventilating. It can tell you if they're breathing quickly, hyperventilation. It can show bronchospasms, and then it also can indicate that you might be achieving ROSC during CPR. But it's just this really nice immediate feedback on how well your patient is using that O2 and converting it and getting rid of that carbon dioxide. And again, the normal value there is like 35 to 45. And sorry, one more thing I'll go back and say on this, because I cannot stop talking about capnography. A high capnography would generally be associated with a low respiratory rate because they're not breathing off that carbon dioxide efficiently. And then a low capnography is generally associated with a high respiratory rate. Okay, so I can't see your question, so don't tell me, but who has ever heard that a drop in O2 sat indicates an aspiration event or trouble swallowing? I'm sure I'm not the only one. I've definitely heard this before, or I've heard people say like, oh, well, his O2 sat stayed at 99% the whole time, so he was fine. He wasn't aspirating. I really like the study done by Steele that really breaks down, is an O2 sat associated with an aspiration event? And what they found was, like we talked about a little bit already, it takes up to or greater than 60 seconds for a change in blood oxygenation to register on the pulse ox. Blood pressure and artery compliance definitely affect that number. And then one study showed that COPD patients swallowing large liquid boluses was associated with a brief drop in O2 sats in 80% of participants without aspirating. And then a similar reaction was also seen in 25% of healthy participants. So they kind of gleaned from this that swallowing a large bolus increases that apnea time during the swallow, which makes sense. And the body responds by increasing the respiratory rate to make up for this in healthy individuals. Longer apnea is more likely the cause of a transient dip in O2 sat during PO intake rather than aspiration. So that super, super brief little dip in O2 that you might see while a patient's eating doesn't really mean that they've just aspirated. And also, it could have been like 90 seconds ago that you're looking at. What vital signs do indicate an increased risk for aspiration? So as far as respiratory vital signs, a resting respiratory rate of greater than 25 breaths per minute is associated with an increased risk for aspiration. Oxygen desaturation is known to not always be associated with aspiration. However, a low baseline oxygen sat of less than 94% is associated with an increased risk of aspiration, which I think makes sense. So really what that's saying is if your patient has a compromised respiratory status, they're going to be at a little bit of an increased risk for aspiration because they're not going to be able to carefully coordinate that swallow, breathe, swallow pattern as easily. There's a higher risk for aspiration when swallow apnea is not bracketed by an exhalation respiratory pattern. This is pretty much impossible to see at bedside if they're doing an exhale, swallow, exhale. But I think it's helpful to think about how carefully coordinated that process has to be. And then quick and high velocity or chaotic respirations are often linked with aspiration. All right, so we got through the A and B and we haven't gone through the C yet. So let's get to a little bit of circulation. Real-time indicators of circulation or real-time indicators of how well your patient is perfusing. So you've got pulse rate, pulse quality, the rhythm of the pulse. So is it really regular? Is it skipping around? And then blood pressure is a good indicator of circulation. And I don't expect every speech session that you go in and take your patient's pulse. I think that would kind of freak people out. But it's definitely something I'm aware of when I'm doing my chart review beforehand, and I do that quick scan of, okay, what have the vitals kind of looked like? If any of these things are showing up in red, that's just going to be another piece of the puzzle for me or another flag, especially if it's super abnormal. And then I included over here how to take a pulse. Most SLPs in healthcare facilities are like CPR, BLS. We know how to take a pulse. This is not related to dysphagia, but I wanted to put it in here because one time I responded to a medical emergency and I was one of the first ones on scene. And the first person on scene was a therapist, not a speech therapist. It was one of our allied health friends. And he was taking a radial pulse on this patient on the ground and looking at the clock. And I walked in and I said, "What's the pulse?" And he gave me the finger and I was like, "Okay, I'll wait." And I started getting my stuff out. I started clearing a path. I was getting ready to take a blood pressure, getting all my equipment out. I waited a second. I said, "Okay, so what's the pulse?" And he looked at me and he said, "0." And that really was going to change the management of the situation. So I always, anytime I have like a platform to talk, I like to remind people that if the pulse is 0, you do not have to wait 30 seconds. Follow your BLS CPR guidelines, but generally 5 to 10 seconds is sufficient. Okay, back on track. Cardiovascular system. The mean arterial pressure is a really good indicator of how well your patient is perfusing and how efficiently that cardiovascular system is working. So I think generally we're really familiar with blood pressure, what's a normal blood pressure. But this mean arterial pressure really indicates how well the vital organs are perfusing. How well is that oxygenated blood getting to those organs? And I have the calculation here for how to calculate a MAP. I really don't think you should have to use this though. Generally, most machines automatically do this, or if you're looking at like inputted vital signs on the computer, usually it's automatically calculating the MAP for you. And the important thing to remember with the MAP is that it takes a minimum MAP of 60 to perfuse vital organs. So getting blood to the brain, to the other vital organs, it needs to be at least 60 for it to be doing it efficiently. All right, this is a little bit of a turn, but I wanted to include the New York Heart Association stages of heart failure. I'm going to run through them real quick and I'll tell you then why I included them. So class 1 would be no symptoms and no limitations in regular physical activity. Class 2 is mild symptoms or slight limitations. Class 3 is marked limitations in activity due to symptoms. And then class 4 is severe limitations, experiences symptoms even while at rest, mostly bedbound patients. So in a study by Plowman, they found that a New York Heart Association risk factor of 3 or 4 on post-operative cardiac patients was a risk factor for dysphagia. So I wanted to include that in here. Which again, if you think about how closely related that cardiopulmonary system is and how closely related the respiratory system and swallowing system is, I think it kind of makes sense. And in the same study, they found a couple other risk factors associated with dysphagia postoperatively. Reoperation was one. TE images greater than 110 were found to be a risk factor. Intubation greater than 27 hours and an endotracheal tube greater than 8 were all found to be factors associated with an increased risk for dysphagia. All right, other cardiac factors in the SLP. There's not a whole lot of research out there as far as like one-to-one cardiac factors related to dysphagia. But there is some stuff out there. So like we said, a MAP of greater than 60 is needed in order for the brain to perfuse adequately, and a diminished level of consciousness is a major risk factor for aspiration. And then I also wanted to include, because we are talking about the cardiac system and dysphagia, a couple kinds of dysphagia with cardiac origins. So dysphagia leucoria is compression of the esophagus by the aberrant right subclavian artery. Dysphagia aortica is difficulty swallowing caused by extrinsic compression of the esophagus by the aorta. And then I'm not going to pronounce this last one, but it is esophageal compression from enlarged left atrium. And I just wanted to include those because I think it's important to remember how close all the organs in there are. So the heart is really close to the esophagus. And can cause issues with the esophagus. So how does health status impact dysphagia management, or how may it impact your dysphagia management for a patient? So impaired health status increases the risk of aspiration pneumonia. We talked about that. It indicates that the patient's condition may rapidly change. It may impact the frequency you see a patient. So if you know their condition is going to change rapidly or may change rapidly, you might want to see them every day versus like 4 days from now. It may impact when you see them. So I think about this patient that I had in the ED recently, who came in, was pretty freshly into the ED, and she had pretty significantly altered mental status. I went to see her. Her vitals were fine. They were okay. But her respiratory rate was really slow. So her respiratory rate was between like 8 and 9. And then she had capnography on, and it was pretty high. It was significantly above normal. But her other vitals were okay. Her O2 was like 92, 90, low side of normal. And she was very altered. And I went to see her, and with her numbers and presentation, my spidey senses were just tingling a little bit that obviously something acute was happening. And she was so altered, I knew that the evaluation was going to be pretty limited. So I talked to the nurse, and there was no like really important PO meds she needed. And I said, you know what, I'm going to come back in like 2 hours and see if things have kind of stabilized out a little bit. And sure enough, by the time that I left, it came back, somebody finally took her blood sugar, and her blood sugar had been like 21, which is very low. So she'd gotten a little bit of dextrose, and by the time I came back in 2 hours, she was completely fine. And probably if I had evaluated her first thing in the morning when she was very altered, I may not have recommended a diet. And by the time I saw her in the afternoon, it was no problem at all. So that's just an example of how it might impact when you see a patient in your day. It can impact the timing of instrumentals. So do you want to get them on first? Do you want to make sure that what they're on is appropriate, or get it done before you start a diet? And then it may impact the kind of recommendations you give. So it may impact how liberal your recommendations are or conservative your recommendations are. And I will say I kind of hate saying that, just because I don't feel like it's generally up to me how liberal or conservative the recommendations are going to be, but rather that's usually a discussion between me and the patient and their goals of care. But it definitely impacts, the risk-benefit analysis of how likely they may be to develop aspiration pneumonia, and has a place in the conversation. Okay, so outside of dysphagia management, there's definitely benefits to recognizing indicators of health status. Healthcare facilities can be fast-paced and rapidly changing environments, and it's important to be able to recognize when a patient's status may be changing. Adverse outcomes may be negated by early detection of signs and symptoms indicating patient deterioration. So it's important to be able to look at the patient in front of you and have a general idea of, okay, is there an immediate problem outside of just dysphagia management? I'm going to go over these super, super briefly so that hopefully we have a little time for questions, but I wanted to include standardized assessments that are out there for medical stability, because the likelihood is your hospital or healthcare facility is likely already using something like some kind of deterioration score. I've worked at a hospital that used Muse, which is they look at all these things right here. So temp, heart rate, respiratory rate, blood pressure, and then they calculate a score. And depending on the score, I wrote it all on here just so that you can go back and reference it if you want. But it kind of indicates, okay, should we call a rapid response? Do we need to get the physician here right now? And then this is simple clinical score, which is very similar. So it looks at vital signs, it looks at comorbidities, and then it kind of gives you a risk of mortality or risk of transfer for ICU. And I included these because I think it's really helpful when you're trying to get that big picture of how well your patient's doing to see what tools you already have access to. So my hospital, I can quickly glide over the deterioration score and see, okay, what vitals are flagging as an issue, and then go from there for kind of building my clinical picture of the patient. The SMART COP is a measure of predicting severity and mortality for patients that already have pneumonia. Some other forms of predictors for pneumonia are not always really good for aspiration pneumonia, because generally aspiration pneumonia has a higher mortality rate than other pneumonias. But a study done by Hayashi out of Japan showed that the SMART COP had pretty good predictive value for aspiration pneumonia. And it's very similar to those other scores. So you look at like respiratory rate, mental status, all these things here, tachycardia, and then you get score to see, okay, is my patient at high risk of mortality, low risk, very high risk? But again, these are for patients that already have pneumonia. So this would not apply to a patient that does not have pneumonia and trying to predict if pneumonia would be severe for them. And interestingly, they found that multi-lobar involvement on the chest X-ray was the biggest predictor of mortality for pneumonia. Okay, the last thing that I wanted to mention, we talked a lot about numbers and kind of objective standardized measures of health status, but I wanted to include this study. So this study found that a physician's rating of respiratory distress was an independent predictor for intubations within 72 hours in comparison with vital signs alone. So basically, the physicians were able to better predict if the patient was going to need to be intubated in 72 hours versus just looking at the numbers on a screen, because the physicians were picking up on little things like facial expressions and patient coloring, and being able to kind of know patient's baseline from if they were not at baseline, things that are a little bit more abstract and hard to catch in numbers. So I wanted to include this just to say that when you are thinking of health status, and especially if you're worried that the patient in front of you has had a change in health status, just because all of the numbers are good, you being concerned about it is enough of a reason to let the medical team know your concerns, because you might be picking up on these kind of more abstract things that might indicate distress. Okay, so in conclusion, it's useful and necessary for SLPs providing dysphagia management to be aware of the interconnectedness of the body systems, health status, and be able to recognize and report change in status. And then, good, I ended a few minutes early. Good, I was so worried. This is my contact information. So I've got my email here. Please feel free if you want the slides. Send me an email. I'm happy to email them. Or if you have any questions or want to ask me anything offline, feel free to email. Or I'm like always on Instagram. Feel free to send me something on Instagram too. I'm gonna exit full screen mode to see if I can see questions.
Yeah, and Eleanor, I can read you the questions we have so
Okay.
far. So Amy commented and said, can we mention the research on pulse ox maybe not being as accurate for people of color? I feel like it is a good one to mention for those who might not know. She said she doesn't remember the name of the study, but she did want to mention that.
Oh, I wish I knew the name of the study. I don't, but yeah, I'll look and see. That kind of makes sense to me because pulse ox is very affected by a lot of things, and that does make sense to me that it would be a little bit less accurate.
The next question is a resting respiratory rate of greater than 25 BPM an adult guideline? And if so, would it be different for children under the age of 1 year?
Oh, this is such a good question. I should have mentioned this at the top. All the numbers are related to adults. Yes, it would be different from pediatrics. I don't know what it is off the top of my head, but yes, pediatrics generally have a much higher respiratory rate. Yeah, that's a really good point. Some of the more general theory as far as the cardiopulmonary system, you can relate to pediatrics, but they present much differently with vital signs, and their indicators of distress versus failure are different than adults too. They tend to shunt more, so they like protect that organ function longer generally than adults. So yes, don't use my numbers for kids.
Awesome. And we still have a couple of minutes. So if anyone has any other questions that you are curious about answering live, feel free to put them in the Q&A or the chat. I'll go ahead and reshare the survey link in the Q&A. Just a reminder that if you are wanting ASHA CEUs, this is eligible for 0.1 intermediate CEUs. You'll just need to complete the survey. And let's see what's today, Wednesday. So by next Wednesday evening, we will go ahead and close the survey and report that to ASHA. Just a couple of notes on ASHA CEU processing. It can take anywhere from 45 to 90 days to see the course reflected on your registry. So if there's a bit of a delay, feel free to email us at tims-univ@tims.com, but that's why there may be a bit of a delay. Let's see, we've got a couple of additional questions. Let's see. Okay, so I think we just answered that one about the pediatric. Next question is, do you have any guidelines for patients on high flow?
Oh, I really don't. Again, I feel like a lot of that depends on the clinical picture of the patient. But I don't have any, there's probably some research out there on exact numbers that you need to be aware of, but I don't. I know that there is a lot that goes into high flow and dysphagia, and I know people have lots of different opinions on it. But I don't have any numbers for you. I have some numbers I'm thinking of, but I don't want to just make something up and throw it out, so I won't.
See, how do you go about advocating for ongoing dysphagia intervention and management in critically ill patients with physicians who may be significantly more conservative than others?
I will say I don't feel like I've run into this a lot because I feel like a lot of times with my critically ill patients, they're like really wanting us in. I think that's hard. I think anytime that we have to advocate to get ourselves into a space where people are not used to having us, it's a struggle. I want to tell you just to be persistent, but I know that sometimes it's like a real uphill battle. I think bringing in the research and kind of inserting yourself is helpful, but I find a lot of times just being really open and talking with the team and not like assuming necessarily that they don't definitely want me in there, but maybe that they just don't know what I can offer and bring to the table, gets me a little bit further. But that's hard. I wish I had a really good answer for you.
I will mention to anyone that's curious about risk management in any patient population, but I think it's important especially when we're thinking about critically ill, it can be nice to have a framework. So obviously we're all familiar with the 3 pillars, but check out the bolus framework. I know I shot that out a lot, but we've done several presentations this year that have talked about that. So that's, I think, a great one and great literature to cite, as Eleanor mentioned, if you are trying to kind of get your foot in the door with critically ill patient populations and then helping physicians understand your rationale. Not that anyone asked my 2 cents, but if you need a resource, check out the presentation earlier this year. Let me put this in. Okay, I popped the survey back in the chat. Let's see. Okay, yep, I did that one. Okay, cool. If you all still need the survey link, let me know. I just responded, trying to respond to everyone. There's another question. Can capnography be used to assess for air trapping during speaking valve evaluations?
Oh, so this is a great question. I think it can be, and that was I meant to ask what was a time that what's something SLPs do that increase carbon dioxide? And yes, the PMV is a great example of that. I think it definitely can be. The only problem is with capnography, the only kinds that I've seen are nasal cannula with the piece that hangs over the mouth, or like the little hook that hangs over the mouth to measure, or the piece that goes on the bag valve mask. And I'm not sure any of them would capture, they just would be like kind of awkward to hold at the PMV. And I think that that is like a real good way to measure with the PMV, but also it generally affects the O2 sat pretty quickly. So I think using the O2 is also totally fine, and is kind of, when that O2 sat drops from the PMV, it's because of the capnography. So or generally it's because that buildup is there, that exhale is what's being affected. So generally, okay, they're going to have a really high capnography. That's what's causing my O2. But yes, I love that.
We have another question. Is there a specific respiratory rate at which you would absolutely not feed a patient?
There's not. Personally, for me, there's not. There might be a respiratory rate where I want to visualize, where I definitely want to be like in fluoro or doing a fees to make sure, but there's no specific number for me, especially when thinking about clinical picture. So if it's a number that is normal for the patient, even though it's really high, that can happen. But no, for me, there's no, like 100 maybe.
I'm gonna recopy all of this really quick just so everyone has it. The information for CEUs and survey is in the chat, but it'll be sent out via Zoom as well. So if you don't get the Zoom emails, feel free to send us an email at tims-univ@tims.com and we'll get you the information over if you're not able to copy it from your iPhone. But if there's any other questions, feel free to reach out to us or reach out to Eleanor. Eleanor, I want to thank you for being our guest speaker this evening, and to everyone who jumped on the call. Thank you for being with us, especially right now around the holidays. It's a busy time, so we appreciate it very much. And the replay of this event will be up on our website sometime tonight or tomorrow. So with that, we'll go ahead and close out for the evening. Thank you all very much.
Thank you, guys.
Bye, everybody.